Hi and welcome to today's presentation on the cervix. Today we are going to look at the anatomy and physiology of the cervix, which is applied in obstetrics. And so the cervix is also referred to as the cervix uteri, and we mean the neck of the uterus. And though this cervix is part of the uterus, its structure and functions differ from the main body of the uterus, and so we try to describe it separately. And so, by way of description, we say the cervix is situated below the isthmus and forms the lower third of the uterus. By way of describing the internal and the external os of the cervix. And the cervix also enters the vagina at right angles and it forms four fornixes. And so we have the anterior and posterior fornixes as well as the two lateral fornixes. I explained this in detail when I was treating the vagina, so you can go back there and watch that video. But the shape of the cervix is fusiform and it looks like a barrel, which I'll show you very soon. And the size of the cervix varies with development as well as age and the parity of the woman. And also, we find that maternal hormones play a major role in these changes that we find in the cervix. And so, during intrauterine life, the cervix forms the greater part of the uterus. And in the last weeks of pregnancy, there is an increased growth in the uterine body due to the high levels of maternal estrogen. Now, during the time of birth, what we find is that the cervix and the body of the uterus are approximately equal in size. However, during puberty, there is further increase in the size of the uterine body due to the activation of these maternal hormones that we've talked about, until the size of the uterus is about twice the length of the cervix. And because of this, we are able to diagnose infantile uterus in an adult woman sometimes by assessing these relative proportions of the cervix and the uterus. Now, in adult life, the cervix is 2.5 centimeters long, and as we've seen, forms one third of the total length of the uterus. Now, looking at the diagram on our right, this is the entire uterus and the cervix, and this portion is where we are discussing today. And so, as we can see, it is situated below the isthmus. The isthmus is the narrowest constriction part of the uterus, and it separates the cervical canal or the cervix from the body of the uterus. And so this is where the cervix is situated. And you can see that it is entering the vagina at right angle. And as it enters, it forms the fornixes. So we have the anterior fornix and the posterior fornix, as well as the two lateral fornixes. Now, as you can see, it also looks like a barrel, in shape. And this forms the cervical canal. So here is our internal os, and here is our external os. Now, let's continue. We are going to continue with the structure of the cervix using this diagram to explain. Now, we have what we call the supravagina cervix, which is also known as the portio supravaginalis. And this is where I'm talking about. Now, this portion of the cervix lies above the vagina's attachment to the cervix and is covered by peritoneum on its posterior surface. And so, the supravaginal cervix is the part of the cervix which lies outside and above the vagina. So, as you can see, this is the part of the cervix lying outside and above the vagina. Now, we also have the infravaginal cervix, and the infravaginal cervix projects into the vagina. And so the infravaginal cervix is also known as the portio vaginalis. And as you can see, this part of the cervix is projecting into the vagina. So this is the vagina, and this is the infravaginal cervix. Now we move on to the internal os, and the internal os opens into the cavity of the uterus and is able to dilate during labor. So this is our internal os. So we have the histological internal os and the anatomical internal os. But basically, we talk about internal os, we mean just one thing. And so, one other important obstetric importance of the internal os is the problem of cervical incompetence. And when we say cervical incompetence, it is the inability of the cervix to maintain and protect the product of conception till term, leading to premature birth or even pregnancy loss. And this is usually due to congenital anomalies of the cervix as well as cervical tears following childbirth. Sometimes also due to overdilation and trauma of the cervix during dilatation and curettage, which is usually performed when we are terminating the pregnancy of a young or any patient for that matter. So during termination of pregnancy, where we do dilatation and curettage, sometimes there is excessive dilatation and trauma to the cervix, which renders it incompetent as well as insufficient, and so cannot maintain and protect the product of conception. It is also due to exposure of diethylsterol, as well as patients who undergo large cone biopsy, which is usually done for diagnostic purposes in cervical cancer screening. And so when the biopsies taken are so large, what happens is that it renders large portions of the cervix incompetent, and so cannot perform its functions of maintaining pregnancy till term. Now, all of these, when they happen, may contribute or may lead to spontaneous, abortion in the mid trimester of pregnancy. Now, when we look at the external os, it is that part of the cervix which opens into the vagina at the lower end of the cervical canal. Now, when we look at the external os on pelvic examination, it is found at the level of the upper border of the symphysis pubis. Now, before childbirth, what we find is that the external os is a small, round, as well as oval opening. And after labor, especially, after vaginal delivery, what we find is that the orifice of the external os is converted into a transverse slit that divides into what we call the anterior and the posterior cervical lips. I will show you a photo of it very soon. Now, during or in the life of a multiparous woman, what we find is that the cervix is circular in shape. It looks very smooth with a dimple in the center of it and is able to admit a fingertip by the 36th week of gestation. In the multigravida, what we rather find is a transverse slit-like aperture which has irregular edges and easily admits the fingertips, and this is what we refer to as the multips os. And so I'm going to show you photos of this, but before that we have the cervical canal, which lies in between the internal os and the external os, and it looks fusiform as I showed you before. Now, this is the cervix in a nulliparous female, and as you can see, it is circular, in shape. It looks very smooth. But when we see the cervix in the multiparous woman over here, we find that the os is looking transverse, and so we have the posterior cervical lip, as well as the anterior cervical lip. And in this diagram, you can see it very beautifully, the cervix in the nulliparous, as well as the cervix in the multiparous woman, as you can see. So this being the anterior cervical lip, and this being the posterior cervical lip. And as you can see, it looks like, a slit-like aperture, transverse in shape. Now, let's quickly look at the microscopic structure of the cervix. Now, microscopically, what do we find? There are three main layers of tissues that we find in the cervix. The first one being the endometrium. And this endometrium is the innermost layer of the cervix, and it contains many racemose glands, some of which are ciliated in nature, and so it facilitates the passage of the spermatozoa. Now, the tissues, inside the endometrium is arranged in folds, which we call the arbovator. Now, this arbovator is able to dilate, during labor. It allows dilatation of the cervix and also prevent it from trauma. Now, in a multi-gravid patient, the arbovator, becomes flattened out, with successive pregnancies. And so in the gravid patient, you may not be able to visualize these foldings of the endometrium. Now, the cervical endometrium is more glandular than that of the main body of the uterus, and it is not also shed during menstruation. However, we find that these cervical, endometrium is affected by the maternal estrogen during ovulation, and so during this time there is increase in the glandular secretion of the endometrium, and it has a lot of importance, which I will explain to you very soon. Now, the next layer of tissue that we find is the muscle layer, and the muscle layer is predominantly involuntary muscle fibers, which is mixed with dense collagenous tissues, and so it makes it more fibrous in nature. It also has both spiral and longitudinal fibers, which run both clockwise and anti-clockwise direction inside the cervix. And the proportion of these muscle fibers in the cervix is largely dependent on the hormone level of the individual. And the last layer of tissue that we find is the parametrium, and this parametrium covers the supravaginal cervix, and it covers it in a very nice fashion. It attaches loosely such that it allows both the bladder and the uterus to modify their positions as required. Now, when we look at this diagram, this is the entire reproductive organs which we have over here. And so as you can see, we have the vagina over here. We have the main body of the uterus over here with its appendages. We have the fallopian tubes and the ovaries over here, as well as some support of the uterus being the broad ligament. But you can also find that we have the blood supply of the uterus as well as the cervix, including the vagina. But since we are interested in the cervix, we are going to focus our attention over here. Now, as you can see, the microscopic structure of the cervix, as we explained, included the endometrium, the myometrium, and the perimetrium. And so you can see that all of these are continuations from the uterus. And so we find the endometrium as a continuation from the uterine cavity. We also find that the myometrium, which is the muscle layer of the cervix is also a continuation of the muscles of the uterus. And as you can see, it is longitudinal and also spiral in shape. And this longitudinal nature of the muscles of the cervix is very, very important because during the first stage of labor, as the uterus contracts, these longitudinal muscle fibers, they contract and they retract. By so doing, it takes the cervical canal up. And so we say effacement has taken place. So it is very important that we have these longitudinal muscle fibers extending from the body of the uterus to the cervix to allow taking up of the cervix, which we call effacement. And as you can see, we also have the perimetrum over here, which also stretches, we have the perimetrum over here, which stretches from the uterine, the body of the uterus, to the cervix over here. Now we have the blood supply to the uterus being the uterine arteries and the venous drainage by the uterine vein over here. So this being the cervical canal, the external os, as well as the internal os. So I think that's all that I need to explain over here. Now let's look at the blood supply and the support of the cervix. Now, basically, we have the blood supply, as we just saw, by the internal iliac arteries through the uterine arteries, and the venous drainage is through the uterine veins, and they finally empty into the hypogastric venous plexus. Then the lymphatic drainage of the cervix is into the internal iliac as well as the sacral glands. Then the nerve supply of the cervix is by both sympathetic and parasympathetic nerves, specifically the S2 and S3. So these nerves are from the Lee-Frankenhauser sacral plexus, to supply the cervix. Now, the next thing we need to also look at is that the support of the cervix. Now, we have three basic supports of the cervix. We have the cardinal ligament, we have the pubocervical ligament, as well as the uterosacral ligament. Now, the cardinal ligaments are also known as the transverse cervical ligament, and they extend from the cervix to the lateral walls of the pelvis. Then we also have the pubocervical ligament, which runs from the cervix to the pubic bone, as the name implies, pubocervical, from the cervix to the pubic bone. Then lastly, we have the uterosacral ligament, which also extends from the cervix and passes backwards to the sacrum. So these are the supports of the cervix. Now, the next thing that we are going to look at is the functions as well as the relations of the cervix. So basically, the main function of the cervix, as we've seen at this time, is to produce mucus. And this mucus secretion increases, especially during ovulation as well as in pregnancy. And so what happens is that in ovulation, the cervical mucus production increases and it becomes more stretchy and stringy in consistency. And so this facilitates or promotes the movement of the sperm by means of providing an optimal environment for its ascent into the uterus, as well as storage and also the survival of the sperm. So this is what the mucus does. Now, after ovulation and during conception, what happens is that progesterone, which was responsible for the production of these mucus, is now produced entirely by the corpus luteum. And so the mucus reduces in its volume and fluidity. And so it becomes more tacky and viscous. And this consistency of the mucus prevents or discourages, the spermatozoa as well as bacteria accent into the uterus. Now we also find that the cervix also helps to prevent infection from entering the uterus, as I just explained. Now, this is very important because during pregnancy, what we find is that it forms a thick mucus plug which closes the entire cervical canal, which we call the operculum, and so it prevents the ascension of infection into the uterus. Then we also have a function as it dilates and withdraws, during labor to enable vaginal delivery of the fetus and the placenta. So I explained this earlier on. This dilatation and withdrawal of the cervix is partly due to the contraction and retraction of the longitudinal muscle fibers, which extends from the body of the uterus to the cervix. And so as it contracts and retracts, it takes up the cervix, and so we say effacement has taken place, and this is what leads to the second stage of labor. Then also following delivery, what we find is that the cervix immediately returns almost to its non-pregnant state. Now, what are some of the relations of the cervix? Now, superiorly, what we find is that the cervix shares border with the uterus at the isthmus. I'll show you a picture very soon. Then we also have anterior, that is in front of the cervix. We have the uterovesical porch of peritoneum as well as the bladder. Then we also find that at the posterior part of the cervix, we have the porch of Douglas and the rectum. Then laterally, we find the broad ligament and the ureters, which are crossed by the uterine arteries, all of it relating to the cervix. And so when we look at this diagram, I think, yes, I have a diagram over here. So in this diagram, what we find is that anteriorly we are having the bladder over here. So as you can see, anteriorly it's the cervix relates to the uterovesical porch of peritoneum as well as the bladder. And so this is the bladder that we can find over here at the front of the cervix. Then we also have sorry, we also find that posteriorly we are finding the porch of Douglas and the rectum. So this is the rectum, and so this is the back side of the cervix. So we are finding the rectum over here. Then superiorly, it's supposed to be on top of the cervix over here, as we saw in the previous diagram. Superiorly, the cervix, share borders with the uterus and the isthmus. Then laterally, what do we find? We find the ligament. So we find the cardinal ligament over here. We also find the ureters also over here, and we have some other structures which also supports and also relate to the cervix. So basically, these are all the little information that I have for you, and I hope it helps you. Thank you very much for your attention. Bye bye.